So welcome everybody to our afternoon session. It's an enormous pleasure for me and Bill to have Professor Gina Brown with us today, who we regard as being the leader of rectal cancer radiology and has actually provided us with scientific evidence for the whole concepts around TME. And it's great that Gina can be with us here today. And I think that just to put the background, there are two real concepts in which Gina has put us in the forefront with radiology. The two concepts that Bill described, the first, the whole concept of TME and the mesorectum in 1982, and then the Holy Plane in 1985. And I think it's an enormous pleasure to have Gina with us. As I said, Bill described the road and Gina has provided us with her roadmap. So Gina, would you like to briefly tell us how you finished up here in Basingstoke?
Well, I think Bill needs to tell the beginning of that story, and I'll pick it up from 1999. But Bill and I met, I think it was in 1996. That's a long time ago. I was a research fellow at Cardiff, and I'll let Bill tell that story.
Well, for me, it's a great moment to have Gina here. Mind you, she's been here lots of times, but to be making this presentation, because I discovered her, and there's a nice little story about that. I was president of what's now really like the London section of our coloproctology societies, the RSM it was then, and I had a Thursday afternoon meeting which was all about imaging, and a young surgeon was going to say that there was no place for this new MRI in the management of bowel cancer. It's a waste of time. And I had the idea that perhaps that wasn't right. And I had a very powerful friend, Janet Husband, now Dame Janet Husband, who was to become president of the radiologists in the UK. And I rang her and she said, well, I think you're right, that it's incorrect to say there's no future for MRI. And there is one young woman who really knows more about it than I do, she said. And she's called Gina Brown. I don't know where you'll find her, but I did find her. I found that she was hidden away in the radiology department down at the Heath, the University Hospital of Wales in Cardiff. And I quite knowingly rang the switchboard and said, and she wasn't on the list of consultants or anything like that, but the telephone operator, she knew. She said, there's a woman who's working all hours and she is to be found in a little room in the X-ray department. Would that be the one? And it was. And she turned up to the RSM meeting and she blew away the idea that there was no future to MRI in our imaging. And of course, the reality is that she changed the whole management of rectal cancer particularly. And that's what we're talking about today.
Gina, over to you after that.
So I think he gives a lot of credit to me, which is for which I'm very grateful. But actually, the truth is that if it wasn't for meeting with Bill and with Phil Quirk, who you see in this photo here, if it wasn't for meeting them in those early days of my research, I don't think I would have advanced the usefulness of MRI in helping patients with rectal cancer to be cured, were it not for their support and their help and their guidance. And indeed, it was through those initial meetings and those initial connections that we grew a very important and subsequently very influential collaborative group called the Mercury Trial Group. All the initial participants are there in the picture, but actually it grew so much that it's now a
Except
global.
for Brendan Moran.
Apart from Brendan, Brendan must have been
I think
hiding
he
in a bush.
sneaked away.
I was probably operating, doing something useful, like doing an operation.
You might have actually been working on that day. But it grew, and with that, the translation of this work to other countries through Bill's enthusiasm, through us being able to share this knowledge with other radiologists, other surgeons, other multidisciplinary teams, who immediately saw the link between good quality, high resolution MRI and good quality surgery. The two go hand in hand, because without the one, the precision surgery becomes challenging, and actually the MR turns out to be a really useful route map for the surgeons. But more than that, for the patients, they know what tumour they're dealing with. When that surgeon meets their patient, shows them the MRI, shows the radiologist's interpretation of the scans, everyone knows what they're dealing with, good or bad. And it also means that we can ultimately give as much preoperative treatment as is needed for that tumour, not over-treating, not under-treating, based on the imaging findings and the very careful interpretation of the scans by expert specialist radiologists, who I'm very proud to have taught around the world and who teach others in their wake. And I think, just like I've took a leaf from Bill's book, which is he's always eager to share his knowledge, his experience, and Brendan, both of them have spent their careers doing the surgery, but also sharing their knowledge with trainees, with international surgeons, with anyone who cares to learn from them. And I think this is a huge achievement for the pair of them within the NHS, and I always look up to their lead as I followed in their path.
Gina, you're being too nice to us. The essential thing...
He says that to all the girls.
The essential thing about all this really was that, you know, a dissection plane I like to define as a dissection that can create a space. A plane is a separation zone containing a realer tissue, and it can, by dissection, be turned into a space. And that corresponds, that mesorectal fascial potential space corresponds with a black line on a good MRI. And you introduced the ability to see it on the T2 weighted images, and that changed everything.
Exactly, and but I can describe it. So here on the MRI, you can see the mesorectal fascia, the rectal wall itself, and the planes that the surgeon is going to encounter when they operate. And actually, the importance here is that if the tumour is extending to that boundary where the surgeon is going to be trying to remove the tumour, they will end up with a non-curative procedure. And how would they have known other than at the time of surgery? So that was where MRI played such a useful role, because we could spot that before the surgery, offer that patient preoperative chemoradiotherapy, which is what you see on the image on the right. The tumour has moved away from those areas of danger at the margins of the dissection, and that patient's had their tumour successfully removed with a beautiful TME specimen that you can see here, and a clear margin. So it's gone from potentially non-curative at the beginning to a completely curative operation, and that patient will survive their cancer. And this is how the combination of imaging and precision surgery has made a difference to patients' lives.
The one thing that I have noticed in my career is that we all sort of educate and encourage each other. So, for instance, the slide on the right is a pathology slide, and it's what Phil Quirk. So Phil and you and surgery have contributed to this thing. And there's this great saying that everybody misquotes, the Chinese saying that a picture is worth 1,000 words. The Chinese saying is a picture is worth 10,000 words. Oh. Actually, it is a real saying. Yes. But actually, yes. And I think it was fascinating, Gina, to work with you in our research as well as our day-to-day work, and to actually look at these pictures and images and plan surgical treatment. And it's in looking into the future, which we'll probably do later on. These sort of images and technology will allow us to direct even surgical interventions in the future, which I think Bill is very keen on in robotics and so on. But tell us a little bit about, initially I think we should focus on what does MRI do for the patient who presents to the outpatients and has a rectal cancer, which is diagnosed as adenocarcinoma.
Yes.
And what can MRI tell us as surgeons? How does it help surgeons? How does it help patients? Clearly it helps patients, but I think the big advance in MRI has been it has allowed surgeons to sort of step back and think and look carefully at the images and see what they might find when they operate. Gina, I'd like you to tell us a little bit about why MRI, because when MRI came in, it's expensive, it was noisy, it takes a long time, and there was a lot of opposition, and the question was, why do you need an MRI? Can everybody have an MRI? And that's important because there's a few patients who can't have an MRI. So could you tell us a little bit about perhaps the background of MRI and how you got interested in MRI?
Absolutely. When Bill met me in 1996, this image here showing E.T.'s finger really summarized how patients were staged, how their cancer was assessed before surgery. And unfortunately, in some parts of the world, that is all that they can have in terms of assessment of their tumor before a decision for surgery. And because it was imprecise, the feeling at that time, as a result of some of the clinical trials at that time, was that every patient, unless the tumor feels mobile, every patient with a fixed or tethered tumor, that means when the finger, well, you can explain what a fixed and tethered tumor is, but my understanding is that you place the finger in the rectum, you move the tumor, and if it doesn't move very freely, then it's fixed or tethered, and that patient needs chemoradiotherapy. Now, I think even the lay public would be a bit horrified that decisions about whether or not they get radiotherapy are based simply on that assessment, but that was the protocol. And actually, when you look at some of the clinical trials, they don't specify that MRI is being used, and that is all that they would have used in some of those clinical trials, even in the ones that are being published nowadays, because what they talk about is clinically T3, T4, without specifying how that T stage has come about. It's a C. Now, what Brendan has very importantly described and published is the use of the prefix MRT, because that tells you that the scan has been done, it's been looked at by somebody who knows what they should be looking at, and is giving the information that's needed for the surgeon to offer the different treatment options for the patient. So the prefix MR rather than C tells you that the patient's been staged using an MRI. Otherwise, you can assume that only the finger has been used.
But I think what's really important though, Jeannie, even if you haven't access to MRI, the fact that you're aware that MRIs are available, you can picture things.
Yes.
And there's no question that the MRI gives us a very objective measurement, whereas the finger, whether it's tethered, mobile or fixed, is really subjective.
Yes.
Depends on the experience of the surgeon,
Yes.
it depends on how nervous and anxious the patient is, a whole load of factors. And I suppose, but why did we get into MRI? Where did it come from? Where did MRI come from?
Yes.
In the background, and where did you get into MRI?
Well, so the point is that didn't seem to make sense to me, and I know that from looking at high resolution MRs in the pelvis in general, there's a lot more information that can be learned from interpreting those images, and it was a case really of learning from our pathology colleagues who had the benefit of these wonderful TME specimens that you could actually correlate against the MRI. And that was how I learned how to look at these scans and provide the information that it doesn't just tell you whether the patient needs chemoradiotherapy or chemotherapy, but it tells you exactly what that tumour is going to be when it's removed from the patient. But you know it beforehand. So if you know that information beforehand, you can have a really good conversation with the patient about what possibilities there might be to offer them a cure. And it may not necessarily be the full TME operation. So sometimes if a very early small polyp is identified and the MR shows that everything is preserved, we can offer a local excision.
Can you just take us through this
Yes.
fairly complicated diagram, Gina? Because it's really important. It's a very important information.
Yes, so it is really the result of 20 years of research so far, and this chart will change, and that's the beauty of it all, because we learn from one another, we learn from the clinical trials, and I've been very privileged through the collaborations that we've together forged. We've been able to complete so many clinical studies to generate the evidence base to separate out the tumours, so that we no longer have a one-size-fits-all approach. It's not that you have rectal cancer, you must have total neoadjuvant therapy. It is, hang on a minute, where is the benefit? What is the risk? Should you really need the radiotherapy? Do you even need chemotherapy? And there are so many different ways of treating a tumour that we can offer, and it should be dependent on what the tumour is doing in the patient. And actually, the patient deserves to have that information to make their own choices, so that they can say, well, actually, if it's possible to remove this tumour without having a major operation, I would like that. Or if this tumour has responded really well to that initial treatment, perhaps I shouldn't be in a hurry to have it removed. Maybe I can wait a little bit longer. And these are the examples of those different approaches. There's also this approach, apart from just giving how much the tumour has gone into the mesorectum, into this package, we can also look at things like whether the tumour has aggressively invaded into the veins. And if that has happened, if the tumour has spread into the veins, then that means the tumour potentially can spread elsewhere in the pelvis, because the veins don't respect Bill's holy plane, it goes beyond. And those are situations where radiotherapy actually helps the patient, as well as really careful monitoring of those patients after they've received all the treatment, because they have such a high risk of developing spread elsewhere in the body. But what we also know is if the radiotherapy reverses that vascular invasion, reverses the spread into the veins, then those patients don't have that same risk of developing spread either within the pelvis or beyond. So it shows that if you give the right treatment to the right patients, you get the benefits you're looking for. If you give that same treatment to everybody, you don't see that survival benefit, because you've overtreated some patients who actually suffer as a result of the excess treatment and who suffer the long-term consequences, and you've undertreated some of the patients who needed a lot more than what they were originally being given. So that's why I think MRI plays such a big role in helping patients survive their cancer, together with the excellence of surgery.
And I think it's very interesting, because when we started this, it was the good, the bad, and the ugly. There were three broad categories. Yes. And it's a very interesting concept, because, you know, a lot of flags in the world have three colours. The Irish flag has three colours, and there's of course the liberty, equality, fraternity, the French. So the three things are really important, because our brains can contemplate three things. So we start with the good, the bad, and the ugly, which is what the Mercury taught everybody, and then you refine each of those groups down. And this is what Gina is doing. Yes. And so we probably really should start with the good, the bad, and the ugly, because that was a really good. And Ian Daniels was our fellow, and that was a really useful concept, and we all still use this good, the bad, and the ugly. And then you refine each of those groups downwards. And it's because our mental, it's about, like at the moment, for instance, with coronavirus, you know, hands, face, space. These are the three things. We remember things in threes. Yeah. So it's really important. So Gina taught us, which we knew already, we didn't know how to measure it or count it, that there were really terrible, the ugly is easy, there were some terrible rectal cancers. there were, so you should never really call a rectal cancer a good thing, but there were some which were really good and we felt pretty confident we could cure. And then there was a group in the middle. And what Gina has given us is some of the technology and the scientific evidence to try and define those groups. But in each group, there are even more definitions and more, isn't that right, Bill? That's
Absolutely.
a really good concept, wasn't it? The whole, the good, the bad and the ugly, which was Gina and Ian Daniels produced this concept.
Yes.
Well, along the way also, Gina's already touched on it, and that is the chances of metastases, which is what most of the patients die of nowadays. The extramural vascular invasion is something she's championed, and which has become the theme, like the Holy Plane is the theme of all my talks. Extramural vascular invasion and its importance is the theme of all yours, I think, nowadays.
I think it's an important theme because it's important for radiologists to understand that we have to look at how these tumours behave and their pathways of spread, rather than the traditional methods of assessing these tumours, which were always based on measuring the diameter of a lymph node. And of course, if you measure the diameter of a lymph node, you no more get the information about the prognosis of the patient than you do if you flip a coin or look at the weather for the day. It is as simple as that. It is not prognostic. Certainly on MRI, it is not prognostic. So if you are looking at something that when you look at the long-term outcomes for those patients with or without enlarged lymph nodes and show that there's no difference, then you have to question if the way in which you've been interpreting those scans is correct. And that's what I try to teach the radiologists, to reappraise what it is they do when they're looking at scans, to make sure that they're thinking about the way these tumours actually behave, and the fact that they mustn't ignore tumour growing in a snake-like fashion along a vessel. That's actually much more important than scratching their heads over the size of a lymph node. And that's really what I've been trying to impress upon them.
Go back to this chart, because if you look at the, it starts at there with MRI-based selection of patients, and the top two are actually what we call the good. The middle is the bad, and the bottom is the ugly. And just take us to those, because the top two are really important. And the one is where it's clearly fairly early cancer, but the second one is not so early a cancer. Tell us about those two top ones.
So the top two are quite important, because actually this group of patients where tumour spread is 5 millimeters or less beyond the boundaries of the bowel wall and into the mesorectum are eminently curable by TME surgery. We know this from all the mercury data that hardly none of these patients got recurrence or metastatic disease, and actually giving them radiotherapy would have harmed them. Luckily, we didn't. We were using the MR to prevent those patients from getting unnecessary overtreatment. But what we found in the outcomes analysis of this, that the nodes didn't add any risk either, that there were no more patients getting a recurrence because they had lymph nodes involved if the primary tumour was behaving itself, i.e. hadn't spread beyond 5 millimeters. And also, as long as there wasn't any vascular invasion, tumour spread into the veins. It means then, for that group of patients, which made up about 30 to 40% of the rectal cancer patients we see, giving all this treatment is not only harmful to them, it prevents them getting such treatment in the future. So if a poor patient with a very early rectal cancer gets irradiated, and then later they get a prostate cancer, they can't be irradiated for that prostate cancer. It's eliminated that possibility for future treatments. And that's what I think people don't realise. And a lot of radiologists, unfortunately, they get pushed, you've seen it, haven't you, in MDTs, they get pushed into saying it's worse than it is, or they don't feel confident enough to say that it's okay, it's a good one for primary surgery. And those poor patients, as a result, end up with more treatment than they needed. So this is the sort of thing...
And worse function.
And worse function. So I think that is a really important group to recognise, and patients also need to be able to understand that.
Gina, you've mentioned the TNM has got itself into a muddle,
Yes.
as we all
Yes.
know.
Yes.
But on your chart there, you're
Yeah.
mentioning T3A and T3B.
Yes.
Just explain that.
Yes.
MRT3 and MRT3.
So it's MR. So you can see the prefix
T3A and T3B. Yeah.
So MRT3A is tumour with spread less than 1 millimetre beyond the bowel wall, and T3B is between 1 and 5 millimetres. So basically that group with a spread less than 5 millimetres do very well. They do as well as the earliest tumours, T1 and T2. There's no difference between them. And lymph nodes in those patient groups makes no difference. But
That's a really hard one for most people to take.
Yes,
it's
interesting.
And I think
Yes.
it's so important and
Yes.
so exciting.
We should
Yes.
stop there and discuss that, because
Yes.
I think that's what that group show is that you can very safely do surgery and remove these nodes, which is Bill's hypothesis. The problem is that the nodes often are associated with other adverse features, which is why, but if you have localized lymph nodes within the mesorectum and you do a total mesorectal excision, you will cure most of those patients. And I think that's the message that in one sense Bill had already identified, but actually people found that really difficult. And I think what Gina is saying, maybe correct me, but is that actually the nodes themselves, if they're removed safely and effectively, they're usually confined to the mesorectum, and actually they don't give you secondaries in your liver and your lungs and so on. But I suppose the aspect is that nodes, and if I was to have a rectal cancer, and I might have one in the future, I'd prefer not to have nodes rather than to have nodes. So I think Gina is right, but they do often correlate with more adverse features, isn't that right, Gina?
Well, that's an interesting one, because actually I'm going to move us to this slide and this slide, because one of the new concepts, and this is really about current and future work, is that there are nodes and there are nodes. And not every round thing that we see in the mesorectum is a lymph node. And it turns out that the pathway of spread from tumour to liver to lungs is not generally via the lymph nodes. It is via a very much faster method of spread, which is the venous system. So you can imagine a situation where a tumour has got into the vein that's draining the mesorectum. Where does that vein go? It goes to the superior rectal vein. Where does that go? It goes up to the inferior mesenteric vein. And where does that go to? The portal vein. Where does the portal vein go? It goes to the liver. So the tumour has a highway, a motorway, super fast transmission to go straight to the liver. And surprise, surprise, the majority of patients who have liver metastases, in fact the figure is in excess of 97%, they will have had vascular invasion in the primary tumour. So
that's an amazing,
yes.
to me, new figure, 97%.
Yes, that's when we audited our patients with liver mets, we found that the primary tumour had EMVI in nearly every case. And so much so that it is really unusual to see a patient develop a liver metastasis in the absence of vascular invasion. This isn't a new fact. The pathologist from the 1930s spotted this, and it's just something that got lost along the way, because people started calling these round things, even though they were veins, they started calling these round things nodes and lymph nodes. And particularly something like this, where you can even see the blood in the nodule, it still gets called a lymph node by some processing and pathologists. When they just see a round thing containing tumour, they will unquestioningly call it a lymph node. So it's perpetuated the feeling that lymph nodes are bad. But actually, when you think about it, why would they be? Because they haven't got a fast method of transmitting tumour to the rest of the body. there is something much faster that bypasses this process.
Yes, I mean the lymphatic pathway's got a series of blocks, which are lymph nodes.
These are filters.
I remember you saying that's actually their prisons along the way to stop that spread.
They're in a hostile environment.
And the other interesting thing is, Gina, lung metastasis. We know, for instance, that patients with rectal cancer have a higher risk of lung metastasis.
So why is that?
Well, you tell us why that.
Okay, well,
I think I know as well. You tell us. Gina knows everything.
It's fascinating. No, it's fascinating because when you look at these images, you see the behaviour of these tumours in vivo, in the patient. You see what the tumour is doing within the patient, and it's making use of the patient's anatomy, unfortunately, to attack the patient. So what happens in the low rectal and rectal cancers is the vascular spread doesn't always just go up the superior rectal vein and into the portal venous system, into the inferior mesenteric vein. It sometimes bypasses that and goes laterally, and it goes to the pelvic sidewall vasculature. And when it hits that pelvic sidewall vasculature, it has access to the main venous system, which is really the systemic system that goes directly to the lungs. So that means that those patients get lung metastases without even getting a liver metastasis. Sometimes the vascular invasion is so bad that it involves the superior rectal vein system as well as those lateral, and so you get lung and liver metastases. But what's very interesting, and this is what really fascinates me and what I want to pursue in the future, is that the ability of the radiotherapy to obliterate those pathways of vascular spread before surgery results in some of those patients not developing metastases compared with those who don't receive that treatment before surgery. So when people talk about TNT, like it's the chemotherapy that's the most important, I don't believe that to be the case. I think the radiotherapy...
Tell us what TNT is.
Oh, okay.
I said it's an explosive agent in most people's mind.
Well, TNT is a new vogue of giving chemotherapy first, then radiotherapy, and then operating. Now, it has some advantages in that if a patient has got high-risk features, they don't have to recover from surgery to receive their chemotherapy. But it has some disadvantages in that if you give it to everyone, you may well be over-treating a lot of patients. And also there are side effects, unfortunately, from giving chemotherapy, not least death does happen if they have awful symptoms of toxicity from the chemotherapy. So it's not something to be given to everybody. But what I'm thinking is that if the radiotherapy does the job anyway, should you even be thinking about chemotherapy in those patients who've responded well to the radiotherapy, because probably the job is done. So
TNT is total neoadjuvant therapy.
Therapy, yes.
So the idea is you give your chemotherapy and your radiotherapy
and then
first.
Nothing happens afterwards.
That's neoadjuvant being before surgery.
Yes.
And then you get your surgery in. But
it's not a huge amount of evidence for benefit from that, as opposed to radiotherapy followed by time with chemo. In other words, consolidation rather than.
Just to go back to Gina's very important point. So you've got two venous systems. The one that going straight up to the inferior mesenteric vein goes straight into the liver by the portal vein, and the lateral spread goes to the heart and then gets pumped out into the lungs, which is why you often get a whole series of lung metastases. So you have the tumor nodules go into the venous system, find their way into the heart, and then the heart pumps them out, and the first thing is going to hit is the lungs, because the venous blood goes right into the lungs. Yeah. But luckily, occasionally, you get maybe one or two cells takes it up in the lungs, and likewise in the liver, which is why liver metastasis and lung metastasis are treatable. But the fascinating thing is that rectal cancer, we know, is the one that tends to go to the lung and often skips the liver completely. It's an interesting concept. Absolutely. It's taken me years to work out I knew that, but it's taken me a long time to get my head around that one. Yes. And also, of course, I know that we used
It's got so many mesorectal lymph nodes in the way.
Yeah.
So
the
the first thing that happens is the lateral fast path.
And if you block the lymphatics badly, then you get lymphatic drainage laterally into the side wall, and you get venous drainage probably as well. But it's really very fascinating with rectal cancer that you do get lung metastasis. But unfortunately, what sometimes happens, you get a whole shower of lung metastasis because the lung is trying to oxygenate the venous blood coming from the body, and these tumor cells are floating in the middle and grow in the lung, which is fascinating.
And that, I suppose, is one of the things that we need to understand is why is it that almost identically appearing tumours can cause such different effects in an individual patient, so there must be some patient factors that relate to how tumour spreads, because you'll see vascular invasion in one patient and it may only produce, as you say, 1 or 2 metastases, and in another it's completely overwhelmed the patient, yet on the face of it they look almost identical. And the thing is that so far we haven't got the sophistication of looking at those characteristics within the patient as well as within the tumour that separate them. So the argument would be that the chemotherapy doesn't actually block the transmission, it dampens it a bit, but it's not going to obliterate those pathways of spread.
But you're very strong on the fact you need both, aren't you?
I think you certainly need the radiotherapy. I think if a patient has the radiotherapy, the EMVI disappears and they have a good response. The chemo has an additional, I don't know what value, because they still do quite well. So I think that what the design of Trigger, if I can bring that point in, is that we give the chemoradiotherapy and then we're looking at the response and seeing what effect the chemo has on the tumour afterwards. Because if we think that radiotherapy is driving 90% of the tumour death, cell death in the primary, then the chemo is going to add a small amount, but not as much tumour cell death as giving a blast of radiotherapy to an aggressive tumour.
Just to go back, remember I started in the beginning by saying there were 2 concepts: the mesorectum, which incorporates the actual fatty tissue which contains it, and then the circumferential resection margin, which is the mesorectal fascia. And Bill's 2 papers in 82 and 85, they were the same thing. The first one was the mesorectal fatty tissue with the lymph nodes, the filter. And the second one was the fascia. And perhaps, Jeannie, you tell us a little bit, because I think what's happened is the ugly one was easy, because that was the one that was going through the fascia. So tell us a little bit about that, and then we'll come back to the futuristic things that we were doing.
Yes. So I think this image. So the mesorectal fascia, we can see the equivalent of Bill's shiny surface that you see on the specimen. That is seen as this low signal, this black line that surrounds the bright white stuff that you see here, which is the fat of the mesorectum. So that line is the line that the surgeon is going to be following for the TME operation. And it means that if the tumour has extended to within 1 millimetre of that line, then there's a risk that the surgery may result in the tumour being close to that cut surface. And we know from all the data that if it's at 1 millimetre or so, or even involving the mesorectal fascia, then that doubles the risk of that patient having a recurrence in the future at that site. So the important thing is to identify such patients on the MRI before they come to surgery, so that they can be offered a treatment that results in shrinkage of the tumour away from that margin. And then, as we see in this case, it means that the patient can have a curative operation. So that was one of the important findings of the Mercury study, is that if we could show that that tumour had moved away from, or it wasn't even involving it in the first place, then those patients weren't going to get a local recurrence, except for in the low rectal cancers.
You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.